Hello everyone, this is Sandy Lewis. I'm Chair of GIN North America, and I thank you very much for joining us on this webinar today. We realized that it required a few extra steps for you to register and download the appropriate software. So thank you very much for bearing with us as we transition to this new platform. Going forward, you will not need to pre-register again, as the system will know who you are. Just a quick bit of business before we start our webinar. The GIN North America Regional Open Meeting will take place during the GIN Conference in Amsterdam next week. Details have been sent to you by email and appear on this slide. If you're going to attend the conference, please do join us for this meeting. It's during the lunch hour on Thursday, October 8th, and there's information on the slide about picking up your lunch ahead of the meeting. Please allow plenty of time because we only have an hour and we do want to start that meeting on time. If you have any questions about this meeting or any other GIN North America matters, please feel free to contact me at any time. And now, on to our webinar. At this time, you all should be muted to ensure a smooth recording. However, you may submit questions via the chat feature at any time during the presentation. We're going to hold all questions until the Q&A at the very end. We're happy to provide you with information today about a relatively new tool for assessing the quality of systematic reviews. As you will hear, it has been in use for several years and received quite a bit of positive publicity in Europe. The creators are joining us today: Belinda Ireland, Rebecca DeKemper, and Leanna Mers. I'm going to start with a little bio about Belinda Ireland, and then I'll give you a little blurb about each of the others before I turn the webinar over to them. So Belinda Ireland is a physician epidemiologist who's been on a mission to bring evidence to healthcare since the 1970s. After completing medical school and a master's degree in epidemiology, she went to work for the CDC, where she designed and conducted health studies in Alaska Native populations. She continued to refine her research skills in a variety of settings, eventually conducting fewer primary studies while generating more systematic reviews of evidence. During her academic career at St. Louis University Medical School and School of Public Health, she directed the research division and taught clinical epidemiology and evidence-based medicine methods to students and faculty. She was the lead methodologist for clinical guideline development at the American Academy of Family Physicians, and later held the evidence-based care unit, and later led the evidence-based care unit for BJC Healthcare, where she represented the organization to NQF and AHRQ. Currently, Dr. Ireland provides evidence-based consulting services to a wide variety of clients as the Evidence Doc, all one word. Rebecca DeKemper. Rebecca DeKemper completed her training in epidemiology at Emory University's Rollins School of Public Health in 1999. Ms. DeKemper worked in social services and public health before switching to healthcare in 2007. Working as a clinical epidemiologist at BJC Healthcare in St. Louis, Missouri, she began her journey into the field of evidence-based medicine. In 2010, Rebecca joined the American College of Chest Physicians in Glenview, Illinois, where she served as a methodologist and later as the manager of Guideline methodology. She recently left CHEST to join Dr. Evidence in Santa Monica, California as a methodology lead. Leanna Mers currently leads the evidence-based care group at the BJC Healthcare Center for Clinical Excellence. Her previous roles include time as both research coordinator and research instructor at Washington University School of Medicine. She holds a doctorate and master's degrees from St. Louis University and has previously published on various infection prevention and occupational health related topics. And with that, I'd like to turn this over now to Belinda.
Thank you so much, Sandy. We're pleased to have this opportunity to share our tool with the audience here today. The three of us, Rebecca, Leanna, and myself, developed the documentation and appraisal review tool, or DART as we call it for short, to meet our needs while we were all employed at BJC Healthcare in St. Louis, Missouri. Now, BJC Healthcare is one of the largest nonprofit healthcare organizations in the U.S., and we're the founding members of the evidence-based care unit there. We were responsible for providing evidence synthesis for patient safety and quality improvement initiatives, for clinical decision support, and supply chain purchasing for the entire system. Resource constraints meant we had to use existing systematic reviews. We needed a tool to help us and our student interns reliably evaluate the quality. So we created the tool. We've received many requests to share that tool and recently published it in an open access journal to allow those who'd like to use it to do so. And today, we'd like to share it with you. Now, we have no conflicts of interest to disclose. And the learning objectives for today include a review of standards for systematic review quality, and also, as you'll see in number 3, the challenges in evaluating that quality. We also will share the DART tool features and its use with you, and we do hope to engage everyone who's listening in sharing ideas for improving quality assessment of systematic review. We're going to do this in a tag team approach. So I'm Belinda Ireland, and I will be focusing in my portion on learning objectives 1 and 3, as I said, the need for quality standards and the challenges associated with evaluating quality. And I'll also share a bit about our discovery of why we needed a different tool for assessing systematic review quality. Now, I know we don't have to tell this audience that systematic review is essential for evidence-based guideline development. I'm sure you'll recognize the cover materials from the Institute of Medicine and from the Guidelines International Network. And also, this is a first slide from a prior GIN North America presentation on the revised standards of the National Guideline Clearinghouse. Both the IOM and GIN standards recommend that guideline developers should use systematic review. Let's see if I can point at these things. Well, you can see, perhaps you can see the arrow, that the recommendations are should use, but that the ARC National Guideline Clearinghouse uses a bit stronger language to require that clinical practice guideline be based on systematic review. Now, I'm sure you all know why an evidence-based guideline has to be based on systematic review, but I wanted to quickly summarize the rationale. Currently, systematic review is the most rigorous and the least biased method we have to find, assess, summarize, and translate existing evidence. But as you also know, meeting those standards for valid systematic review is anything but fast. Now, given that it is a resource-intensive process, I'd like to ask the listeners now if they primarily conduct their own systematic reviews, if they contract or nominate out topics for systematic review, if they rely on pre-existing systematic review, if they use some combination of those, or if they're not yet using systematic review. And we're going to do that through a poll. So if you could submit your answers, we'll leave it open for maybe 15, 20 seconds to give you a chance to let us know what is your current practice for guideline development. Well, thank you for your responses, and it looks like most of you are doing some combination, although some of you are conducting your own systematic reviews. and some, I guess, are using exclusively pre-existing systematic review. That was certainly our experience at BJC because of the resource intensivity of that process and our limited resources. That was what we chose. But it's interesting to see that most of you are using some combination. So for those of you who, like us, are relying on existing systematic review for at least part of your evidence, you know there's been an explosion in this. So in a 2004 estimate, we have 2,500 a year. And then in a 2010 estimate, there was roughly 4,015 per year. And just yesterday when I was on Twitter following the Research Waste and Equator Joint Conference, I don't know if others of you were following that, but they have great Twitter feed. Anyway, I found a slide there. One of the presenters had said that currently that number is up to 8,000 per year, which amounts to 22 systematic reviews a day. So how do you know any individual systematic review is any good? Even though standards exist and the methods for conducting systematic review have been improving, there's still inconsistent execution of those methods. Reviews in the past were often limited by the biased selection of studies that supported the prevailing belief. Now you may recognize, because this was in the news last week, that this is a photo of Yogi Berra. Yogi Berra is a St. Louis native, grew up on the Hill, famous not only for his baseball career, but also for his yogiisms. He's reported to have said many things. One of his famous yogiisms is, "I really didn't say everything I said." But another is, "If I hadn't believed it, I wouldn't have seen it." And I like to use this one because it's a good way to describe the bias of discovering evidence that supports your prior belief, and then the cherry picking of studies to provide supporting evidence. Another way that reviews of the past were limited is by studies that were easy to get. Now, as Sandy said in my little bio, you probably figured out I'm pretty old, and at the time I started doing evidence reviews, the only way to get access to this is pre-internet, folks, so the only way to get at it was to dig out the Index Medicus, and many of you have probably never seen this and don't even know what I'm talking about, but it's a big book like a dictionary, updated periodically with a listing of all the studies that were published in, whether it was quarterly or semi-annually, I don't remember now, but these came out fairly often, update new studies, and you physically had to go and look through them by hand. And then once you found your, and so you had to think of what could things possibly be called, and so if I'm looking up gout, I'll look at gout, and maybe I'll look at colchicine since it was pretty much the only drug. And then you'd track down the studies, write them down, and carry this list and go down to the stacks and physically pull out the hardbound published copies of these studies. Now, this did not lead to any easy systematic way to do anything, so it's not a surprise that many of the reviews of the past weren't very systematic. Another problem with studies of the past is the lack of study quality assessment. Now, unfortunately, this problem persists today, and we have some studies looking at it that have evaluated that study quality assessment is often not completed or not conducted properly. So studies of low quality and at high risk of bias could be lumped with the good studies, effectively combining bad measurement with good. But now we have standards. We have detailed standards for conducting systematic reviews from the IOM. We also have them from ARC, and we have them from others. We have the PRISMA standards for reporting systematic review for publishing, and we have standards for evaluating existing systematic reviews from the Overview Quality Assessment Questionnaire, which is also known as Oxman-Guyot, from the Assessment of Multiple Systematic Reviews, AMSTAR, and the just released Risk of Bias in Systematic Review. and yet the quality of systematic reviews vary. So before you can use a systematic review as the evidence base for your guideline, you have to evaluate it. You have to make sure, first, that it's clinically relevant to your question or questions, and then that it was built from systematic, pre-planned search and selection, not from cherry-picked or studies easy to find. And you have to assess the selection criteria as well as the quality of the data retrieved by an individual study. You have to assess how the author synthesized the evidence and how it was turned into usable evidence. So you're going to need a thorough look to evaluate. You're going to have to get down and dirty and roll up your sleeves and look at the data. I'm sure you all know the standards, and so do the developers of Oxman Guide and Amstar. And these, again, similar to that list we just went through, you have to predefine your question. You have to predefine your search database and terms. You have to predefine the study features you'll include or exclude. You have to predefine quality standards. You have to predefine data extraction. And you have to predefine your analysis plan. Now, even though all of these concepts are basically included in the Oxman Guide and Amstar tools, we found that they didn't meet all of our needs. So we identified these additional needs. Since we needed to summarize evidence for all types of clinical questions and not just interventions, we needed a single tool that was able to evaluate a variety of research designs, not just RCTs, but also observational studies. We needed the tool to have more structure and detail so that junior epidemiologists and student interns still gaining practice with the methods could use it with minimal oversight and direction. We also needed space for recording notes as we reviewed to facilitate evidence review updates so that we didn't have to waste time recreating prior reviews. And we needed standardization across reviewers. So that's why we set out to create a tool to meet all of our additional needs. And now I'm going to turn the presentation over to Rebecca to describe the first parts of the tool development process and to introduce you to the features of DART.
Hi everyone. Thanks Belinda. I'm Rebecca Dekemper, and now I plan to discuss how we created the DART tool. So before I really get into discussing our tool, I wanted to start out with a polling question. So I would like for us to take a moment to answer the following polling question. Are you currently using a tool to assess the quality of systematic reviews? Yes or no? And we'll give you about 15 seconds to go ahead and enter your responses. Okay, so it looks like 64% of you currently are using a tool to assess the quality of systematic reviews. So that's good. So now we'll follow up with an additional polling question. If you are using a tool for systematic reviews, which tool are you using? Are you using the Oxman Guide or OCAC tool, or are you using Amstar, or are you using another published tool such as DART or Robus, or are you using a tool that you created? And again, we'll give you about 15 seconds. Okay, so it looks like 56% of you are currently using AmStar, and then we do have about 17% using another published tool such as Dart or Robus, and then 26% are using a tool that you've created yourselves. So now I'll kind of get into our whole process of how we developed the Dart tool. Dart was developed over the course of a couple years and involved multiple phases of development. First, we searched for other tools that were already being used to assess the quality of systematic reviews. After we identified other tools, then we evaluated those tools for their strengths and weaknesses to determine the items that should be included in our tool. We used Excel to create the tool and formulated the questions directly in that Excel spreadsheet. After we included the major elements of our tool, then we formatted the tool to make it more user-friendly and added the rationale sections. Then the tool went through several rounds of pilot testing, and we revised the tool based on the feedback we received throughout the pilot testing process. We then conducted additional testing and continued to revise the tool further. When we started looking for other tools that were being used for systematic reviews, we started by looking at the Cochrane Handbook for Systematic Reviews of Interventions, as well as a Sachs article on meta-analyses of randomized controlled trials. And of course, we also used ART as a resource for looking at how to evaluate systematic reviews. Ultimately, we identified two validated tools for assessing the quality of systematic reviews. The OCAC tool, which is also known as the Overview Quality Assessment Questionnaire, which was developed by Oxman and Guyot, and then also AmStar, which is also known as the Assessment of Multiple Systematic Reviews, and it was developed by Shea et al. So as Belinda mentioned earlier, we did have several needs that we were trying to address when we sought out to create our own tool. So as we were determining the criteria that should be included in our tool, we identified the several needs that we had that were not being adequately addressed by either the OCAC or the AmStar tools. And they included the need to have a standardized quality assessment process, the need for a single tool to assess a variety of included study designs, such as randomized controlled trials and observational studies. We also wanted to be able to have a detailed record of the review to facilitate updates of the evidence review. And we wanted a tool for training junior epidemiologists as well as other reviewers who may have limited methodology experience. The OCAC and AmStar tools either did not sufficiently address these needs, or they included questions that led to inconsistent responses from the reviewers. When we were developing DART, we wanted to make sure that it could be used by anyone regardless of their background and experience in reviewing systematic reviews. We wanted clinicians, guideline developers, researchers, students, and other users to be able to use our tool. With this goal in mind, we created comprehensive questions with answers that provide additional guidance to inexperienced reviewers. Another goal we had in mind when we were developing DART was that we wanted to include space for documenting where the systematic review reported on an item being assessed. The additional space also allows the reviewer to explain how they arrived at their assessment of that particular item, and it facilitates reconciliation between reviewers as well as facilitating future updates. Another feature unique to DART is that it not only assesses whether a systematic review performed risk of bias assessment, but it assesses how well a systematic review assesses studies with varying study designs. This is an important feature because more systematic reviews are including observational studies and are no longer being limited to just randomized control trials. We also thought it was important to assess whether studies included in a systematic review are synthesized appropriately. In cases where there is substantial heterogeneity, it's not appropriate to pool studies with noticeably different populations, interventions, outcomes, study designs, or treatment effects. Review authors need to state that they assessed for heterogeneity and how they accounted for it if heterogeneity was detected. Systematic review authors should also disclose whether they have any financial or intellectual conflicts of interest and whether any potential authors were disqualified from serving as authors on the systematic review due to their conflicts of interest. We also wanted to include an overall assessment of quality, which is based on a 10-point Likert scale. We chose a qualitative scale instead of a quantitative scale because a quantitative scale would need to include a system to weight some of the questions over others, and we felt that any weighting system we developed would be somewhat arbitrary. After we developed DART, we compared it to two other validated tools, which I have previously mentioned, the AmStar tool and the OCAC tool. The DART question examining risk of bias in the included studies was more detailed and accounted for different study types compared to AmStar and OCAC, which included more broad general questions on quality. So in summary, DART provides a standardized way to assess the quality of systematic reviews, allowing for more consistent responses. It also includes additional space to document user rationale, which facilitates reconciliation and updating. It evaluates systematic reviews, including observational studies, and it can be used as a training tool for junior epidemiologists and others with limited experience with evaluating systematic reviews. So now I will turn it over to Leanna.
Great, thanks Rebecca. I'm going to talk now about the DART pilot testing and tool revision. So after initial development of the DART tool with input from AHRQ, epidemiology principles, OCAC, AmStar, and the Cochrane Handbook, the tool underwent multiple rounds of pilot testing before the final version was produced. During the first round of testing, an internal group of 6 methodologists reviewed and pilot tested the tool. And then over several weeks, systematic reviews of varying quality were critically analyzed using our tool. This exercise resulted in several revisions of the tool, and by the end of this testing phase, we determined that the tool was designed well enough to elicit consistent responses and agreement regarding the overall quality of the studies that we reviewed. The second round of testing focused on the review of systematic reviews using DART, in addition to the modified OCAC and AmStar. The goal of this round of testing was to compare the performance of DART to these two widely accepted and validated tools to determine if our design goals were met. 4 internal reviewers, 3 of which are sitting here on this call, with varying levels of training and experience, ranging from a Master's of Public Health student intern to a faculty epidemiologist with over 30 years of experience, Belinda, used the 3 tools to independently assess the quality of several published systematic reviews. The reviewers then used a modified nominal group technique to brainstorm the strengths, weaknesses, and suggestions for improving the tool. The reviewers also compared the performance of the 3 tools and identified variation in the responses to the quality assessment questions. So the 3 tools were then mapped against each other, and this table is pulled from our publication that Belinda talked about before. And they were mapped against each other to identify and characterize areas of overlap between the questions in order to determine if our design goals for DART were met. After evaluating results from the content mapping and comparing our performance and utility of DART for reviewers with different levels of experience, the tool was once again revised. A 3rd round of pilot testing was performed using the revised tool to appraise the quality of different systematic reviews. As a final review of our tool, we compared DART content to the 2011 Standard for Systematic Reviews from the IOM to ensure that the tool included an evaluation component for each of the IOM standards. And then final modification of the tool was completed in April of 2011, followed then by additional rounds of internal pilot testing to evaluate inter-observer reliability, or the consistency of responses for each question when the same reviewer appraised the systematic review at different points in time, and also to evaluate inter-observer reliability of the tool when used by different reviewers. The DART Quality Assessment Tool has been used by BJC Healthcare since the completion of development and testing in 2011. Our evidence-based care team is responsible for completing evidence reviews around various clinical questions and the quality assessment of existing systematic reviews. And this is a critical part of the process. So Rebecca's going to come back on now and talk about how the tool was used in her previous work experience.
Yes, so when I was at the American College of Chest Physicians, there were times where we would come across published systematic reviews that addressed PICO questions that we were interested in addressing for some of our clinical practice guidelines. So we started using DART as the tool to assess systematic reviews, which then informed the recommendations that were published in our guidelines. And I will have Belinda share a little bit about her experience through her company, the Evidence Doc.
Yes, so now as a consultant, I don't have all of the same needs that I did when we developed this, but I'm still finding that the most valuable portion of the DART tool for me is the recording. Even though I'm not always, sometimes I'm still doing double for some of my clients, and that's great. It provides that opportunity. And again, using the recording, the space for recording detail, facilitates those discussions between why I got what I got when we have to arbitrate differences in the review. And it really helps me when I go back and need to look again at an old review that I know I've done a while back. It's really handy to have that tool on file and to be able to, I use the recording option for putting things as specific as page numbers, even sometimes direct quotes, so that I can help remember why the decisions were made about the quality.
And so this next slide just shows where you can get more information about DART on the Evidence Doc website, and then also a citation to where the tool has been published. Okay, so now we'll turn it back over to Sandy.
Okay, thank you all very much. This was very, very interesting. I enjoyed it very much. I hope others did as well. Belinda, I just want to point out that I never said you were old, but I actually did enjoy hearing your story of how you searched for evidence in the early years of your career. It provides not only interesting scenarios for us to, imagine what that was like, and we can certainly put ourselves in your in your shoes struggling to find all of the evidence. But also it provides a really convincing explanation for why we really needed to have a change in the process to make it more systematic and more comprehensive, and eventually to lead to established standards. So found that very interesting. Thank you for sharing that. Okay, I do want to mention that if you have questions and you have not yet submitted your questions, please do so in the chat box, and we will be addressing the questions over the next few minutes. So let me start the questioning, if I could, by asking if the three presenters would share a bit about your early recognition in Europe, because you had some very positive attention there, and I'd like you to share that with our audiences, please.
Hi, this is Belinda. I think you're referring to our presentation at the Evidence Live conference a couple years back.
Yes.
Yeah, we did get a lot of interest, and especially what was most interesting to me, Rebecca can share if she had different observations, but the people that approached us and talked about it, what was interesting was hearing some of the same problems they were having with the prior tools, and especially even with Amstar, that sometimes there was a little confusion about choosing an answer, what the question was really asking. Was it asking about reporting? Was it asking about not as explicit about whether or not, I'm trying to think of one of the ones in particular. One of the really challenging questions was about conflicts of interest, I think, on the Amstar tool. That particular question was confusing to a lot of folks. So it was interesting to hear that we weren't the only ones who had challenges with the tools that existed, although not as many approached us about our specific needs, and in particular the one about we had varying levels of trainees and really needed something that was more directive than the existing tools. Did you have a different experience?
Yeah, this is Rebecca. I don't have anything really additional to add to what Belinda said, but we did have a positive experience at the Evidence Live conference. And then we also had a poster presentation at the GIN conference in San Francisco. So we also had fairly good feedback also from that. And since then, it's just been a matter of trying to fine-tune our tool and also get it published so that we can be part of the conversation and hopefully part of the solution to finding a good tool for assessing the quality of systematic reviews.
Okay, very good. Well, thank you for that. Thank you for sharing that. I do have a couple of questions that have come in. Let me mention that one of our questioners has shared similar experiences to what you outlined, Belinda, and wanted to share that, and reports that one of the issues she has with other tools is a focus on whether the study reports something, sometimes without a clear place to indicate that it was clearly documented, but the methodology itself was poor. For example, they described their search strategy to a T, but clearly missed key databases and search terms. So she would like if you could spend a few minutes addressing this problem, and reports that it's especially prominent in Amstar. So the issue here is that other tools just focus on whether the study reported some item that was part of the tool, not so much on how it was reported, how clearly it was reported, how thoroughly it was reported, but just whether it was reported.
Yeah, we're trying to get back to the slide maybe where we can show how we addressed it in in DART. So give us a minute to find some examples here. I know that we face that challenge too, and one of the things we noted, and the way we handled it, I guess, was by offering partially as an option instead of yes if something wasn't clear. So let us get a good example here, and maybe Rebecca can.
Yeah, so obviously, I mean, in some parts of our tool we have simple kind of yes-no responses where it was where we recognized from our pilot testing that it was a little bit more straightforward to be able to give kind of a yes or no response. But then in other areas where we didn't feel comfortable necessarily giving them full credit for having done something correctly, then we also added that partially response. So you can see that in the question for publication bias. So did the authors make any statements about assessing for publication bias? So sometimes you'll see in systematic reviews that with publication bias as an example, that the authors will state that they assessed for publication bias, but then there's no follow-up in terms of them saying, well, if they did find publication bias, how they actually accounted for it. So we did try to build that into our various questions, and then that's also why we have that rationale space, so that if someone was having trouble maybe answering a question, they could also document their rationale in that field.
Okay, there's a follow-up to that question, that the issue is more about the clarity versus whether it was done well at all, confusing the quality of reporting with the quality of the actual work done.
Take that.
Yes, well, that's a very good point, because that's definitely something that we've encountered when we've reviewed systematic reviews, and to some extent it ends up being a judgment call. I mean, you can also try to go back to the published protocol if that's available, and potentially get more information there about whether the authors did appropriately apply the methodology that they said that they were using.
This one was one that we had a lot of discussion about during our testing too, and you'll find that during our development and during testing that this is when I think personal, I don't want to say personal bias, but personal approach to how stringent you are. I tend not to give anybody credit if they can't explain to me carefully what they did and why they did. So I tend not to be one of those lenient folks when I read it. And if the reporting is unclear, I can't tell what you did, you don't get credit for doing it properly. Now some, if you have time, and again, remember we were resource constrained and had to do a lot of systematic reviews and had to come up with evidence, supportive evidence rather quickly. If you have the luxury of performing systematic review in an environment where you have that wonderful year to get things done, then you can track down authors and grill them. And you can ask them, how did this paper says, now what did you actually do? Because we don't have enough information in here to evaluate based on your reporting. It's been hoped, of course, that PRISMA with the standards for reporting will improve the quality of reporting so that we'll be able at some point to assess what the quality of what was actually done. But I think we're still today struggling with that, just as the questioner has said.
Okay, another question is, was DART tested or piloted using people not involved in the development of the tool, perhaps methodologists from a different institution?
No. So when we developed DART, we very selfishly developed DART to meet our needs. And we really didn't have as a goal publication or development of a tool that would have any widespread use. So the tool was developed and rigorously tested in our own environment by us. Well, I shouldn't say it was tested by those who didn't develop it in specific, in the follow back and in all of the discussions and iterations, but not outside the institution. So there's actually two questions there, I think. So no, we only tested it with people, with users within the institution. Now, it has been used since then outside the institution, but I don't believe in any of those settings it has been formally tested, although it's been informally tested where it's been applied to see if it meets the needs for those organizations, but I don't believe there's been any formal testing outside of BJC.
So was there any comparison of DART to any other tools on the same systematic review? Even if it wasn't a formal, research project?
Yeah, so our entire pilot testing process was built around us reviewing published systematic reviews using the OCAC tool, the ANSTAR tool, and the DART tool. So Belinda, Leanna, and I were involved in that testing throughout, and then we also had interns. We had a PharmD and another epidemiologist from another hospital within the institution. All of them were part of that process where we would take a systematic review, and all of us were required to use all three tools to assess the quality of that one systematic review. And then we would compare the answers that we came up with to each of the questions in that tool. And so we did find that through that process that our tool was consistently eliciting responses that were more consistent across all of the reviewers that were part of that pilot process. With AMSTAR, we didn't find that same consistency. And we also found that when we would go back and look at our own responses for a particular systematic review, that we didn't even have our own intra-reviewer consistency. So one reviewer might have answered a question in AMSTAR one way, and when they went back, they realized, well, they weren't even consistent with how they were answering that particular question, because they would realize later that, no, their response would change based on how they interpreted that information using one of the other tools.
Did you do any, I know it's kind of new, but did you do any review of ROBUS? And did you look at how DART compares to the new risk of bias and systematic reviews tool that was developed by the people at Cochrane?
No, because ROBUS was published right around the same time that our paper was published, we have not had a chance to do that comparison.
Okay. My team here at BJC has informally done that, but not in any sort of way that we are ready to discuss or present our results, but it's definitely something that we've considered.
Good. So I want to ask you a bit about the past and a bit about the future. So looking back over the reviews that you've assessed using DART through your experiences and through experiences you've had at multiple, in multiple settings, were there any surprises where certain specific elements seem to really stand out as being, considerably poor compliance with the standards or considerably better compliance than you would have expected?
From my standpoint, I feel that systematic reviews that have been published more recently, especially since the IOM standards have come out, you can definitely tell that the systematic reviews are kind of trying to follow those standards. So I have found that more systematic reviews are starting to score higher using DART than when we first started this process. But occasionally, I mean, you will still come across systematic reviews where they did the comprehensive search for literature really well. They had that part down, and then they kind of fell apart later on in their systematic review process and ended up, so that's where I think that the DART tool is a good tool, because it doesn't just rely on looking at how well a systematic review author conducted their searches, but it also looks at quality assessment for all of the studies included in that systematic review in a much more detailed way. So looking at all the elements for risk of bias instead of using kind of more of a general question. And it also looks at how well the study authors incorporated the quality assessment into their overall conclusions, and how well they actually synthesized the results from their review.
So I wonder if it's not just a matter of over time, but maybe even within the reviews there would just be areas where you're just disappointed in how poorly reviews are conducted across one of the criteria, or one or more of the criteria. Do any of those specific elements stand out?
For me, yes, and I kind of touched on it in this, Belinda, in my intro about problems with systematic review, where I mentioned the quality assessment. So when I talk about looking through the stacks, and that's an old problem that's gotten better. Just as Rebecca says, it's easier now to do a better search, and so you do find that the searches are better, and that helps to sometimes it helps to correct that preconceived notion or the cherry picking problem too. But what I find consistently remains problematic in systematic review is the quality assessment of individual studies, and I think that's just what Rebecca was saying, that remains, in my review of systematic reviews, the biggest challenge in quality, overall quality of a systematic review, is the lack of detailed quality assessment of the underlying studies.
Mm-hmm. It's all very interesting. Thank you so much. So you all have done a lot of work up until this point. What are your plans going forward? I know you've recently published the tool. Do you have any other publication plans?
So we periodically discuss amongst ourselves to actually externally validate it, which I know is a question that we've had here, and it's a question we get when we talk about the tool, when we present the tool. So others have been interested. It's been interesting to us because, again, we selfishly developed this tool to meet our needs, to find that others have been interested in it, and they've sort of driven us to publish, and then are now pursuing us to also externally validate. So we're at the stage of discussing amongst ourselves, but don't have any formal plans devised yet to do that.
Okay, well, thank you very much. This was very interesting. I don't have any other questions, and no other questions have been submitted. Is there anything else that the speakers would like to contribute at this point?
No, thank you.
Okay, well, Thank you very much. I found this very interesting, and I hope others did as well. On the screen in front of you, you will note that this session with the webinar recording and the slides will be available in about a week on the GIN website, and the link is there for you. And we hope that you'll join us again for future webinars. Our next webinar will be in November, so watch your emails for important announcements. And if you are coming to the GIN conference, please do join us for that open regional meeting. I'm going to advance the slide one more time so you can see information on the meeting. And please note the room number and that you should collect your lunch in advance, but please try to promptly attend the meeting because we only have 1 hour. Okay, well thank you all very much. I thought this was excellent, and thank you to our audience. And we look forward to reconvening again for our next webinar in November.